Certainly want to thank you again, Dr. Uribe, for participating in today's discussion. Again, I'm Pete Marzano. I lead our clinical professional development team on behalf of the organization, and really pleased to host each one of you, and thank you for your engagement tonight, gentlemen. And Dr. Uribe, without further ado, we're going to shift the deck over to you.
Thank you, all of you guys. I'm in Nuesi for putting this together. You know, it's a lot of background job by Pete and his team, and Mike Jensen and his team. I'm very excited because, you know, nowadays sagittal alignment is becoming like an old topic, but believe it or not, we find a lot of gaps. There is a big misunderstanding. People think that sagittal alignment is only for deformity. And what I want to show you today is that actually sagittal alignment, it is important more on degen cases, 1, 2, 3 levels that are actually on the big deformities. So we're gonna have a little bit overview, which ones are the parameters, how we handle the normal values, and then most importantly is how you apply this to the regular day-to-day procedures, you know, how you transfer all these spinopelvic parameters and sagittal parameters to the regular practice. So I just want to start with something which is very interesting. You know, when I was training as a fellow, there were three main goals to spine surgery. One was to decompress, you know, release the nerve structures and anything that was any neural elements. Second was stabilize, if the case was that, and then have a fusion. So you have these three things together, you were having a, you know, I would say a successful procedure. But the problem is what we were finding is patients come to you and you see them fuse and good decompression, but these people were miserable, still complaining of back pain. And the problem is we later find out that actually we're missing one part, which is this one. So we were not paying attention. More than restore alignment was to preserve what we have. And we were losing a lot of lordosis at that time, especially doing PLIFs and some of the posterior lateral fusions at that time. We were not very, we didn't have enough knowledge to know that lordosis was such a big deal in order to keep the balance of the patient. So you see here, this woman showed up to me. I remember it was a woman in the 60s, realtor. She came to me like with a previous laminectomy, which is, you see a decent decompression at 4. You guys see my cursor on there or not? Okay. Yep. Previous decompression at 4.5 and 5.1, but then she showed up with what seems to be a spondy grade 1 at 3.4, and also some degeneration and retrolesthesis at 2.3. So at that time, I remember I like, oh, it's a perfect case for an XLIF. So I said, I'm gonna do laterals there, put PERC screws, and you know, I think this woman is gonna do great. So this is what I did at that time. Yeah, so I did a 2-level XLIF, PERC screws, and I leave it like that. So we're gonna start from now on, you're gonna start looking what happened with the follow-up of this woman at the proximal level and at the distal level. So a couple of mistakes in here is like, I was fusing a very rigid segment on the top of a previous laminectomy and level that was very unstable. So imagine, you know, this one should be straightforward going to the sacrum. Not to mention, obviously, I not even know what was the lordosis of this woman pre-op, and I was just trying to do my best putting screws on a rod. But what you see here is, this is the first follow-up. As you see here, she came, you know, I'm doing good, this and that, but start looking at the spondia 4.5 and then look at 1.2, what happened. So this is 6 months post-op. You see what happened. Retrolesthesis at this level. This spondy start getting worse. Then 1 year post-op, this woman came with like a kind of hip pain and this and that. So she was like, no, I don't want anything. And I said, well, let's get an injection. The pain was from the hip. We did an SI fusion. Obviously, she's not doing better. And in the meantime, take a look at 1.2 and 4.5. So now 1.2 basically is totally degenerated. And then 1.5 years after, you start kyphosing the proximal level. Then it's vacuum phenomenon on the distal level. There's almost no foramen at 4.5, and she was worse. And then 2 years after, no matter what you do, now she was bone in bone, kyphotic at 1.2, grade 2 sponding at 4.5. So this woman finally get the 3-foot standing x-rays, and take a look what I had, you know? So this woman was absolutely out of any balance, you know? So she was basically at least 25 degrees out between the pelvic incidence and lumbar lordosis, not sagittal balance. And you see here, this is the CT just before the last surgery. So you see how 1, 2, and 4, 5, that looks really bad. You see the MRI, kind of what she ended up having. I'm gonna show you a little bit on the Scully films, but if you're looking here, oh my God, this thing block itself. Okay, so you're looking here, stay there. Doesn't like me. So you're looking here, go back. Okay, if you're looking here on the CT, take a look what she ended up having. She ended up having an ALIF with a hyperlordotication 5.1. Then you have to have an XLIF on 4.5, then an ACR at 1.2, which is, I'm glad that he opened good, and then another XLIF up, but the whole story is that she ended up having a T10 to the pelvis, so which is a really bad thing. So take a look at this woman. She went through a million things, and just because at the very first time, I didn't have an idea where was the position of the pelvis with relation to the spine, or the spine related to the pelvis, and she was out of balance. I fused it flat, and then I create 2-3 years of misery on this woman. So you see how a degen case can end up in a nightmare, yeah? So the first question that I have for you guys is, how many of you guys measure spinopelvic parameters like before every thoracolumbar case? So I don't know, Pete, you guys know how to raise hands in here or something on Zoom? It's kind of, maybe you guys raise your hand on the camera. I can see how many of you guys.
Kevin?
Yeah, I measure it like on nearly every case.
Okay.
So I was just raising my hand to do that, yeah.
Okay, Pete, do it also, looks like. Zach, do you do it also?
In most cases we do. Yeah.
Yeah, I mean, if you don't do it, don't worry about it. You don't, you can say no. This is not we're not discriminating. I just, and what about you other guys? Hardeep, Ook, and Michael, and Chris, and Quinones. Oh, you guys do it all the time?
Most of the time. I wouldn't say every time.
Okay.
Yeah, I echo that. I'd say most of the time. Not every time, but most of the time.
So the good thing is that make sure that, to me, most important than measure them, which is very important, I know, and you know that it's softwares and things to do it, is more than anything, be aware that you have to have in your mind where is this spine with relation to the pelvis, because what you don't want is to fuse someone on the wrong way. And I'm going to show you a little bit in here. I don't want to take too much time of you guys, but I'm going to show you why sagittal alignment is so important. You know, why we think sagittal alignment, actually you have to pay attention to it. And this is, back it up with multiple literature. So you see the reason number one is there is no question that if you don't have the patient on balance, there is a lot of disability. These people don't do good. They keep complaining of back pain, and then if you don't fuse them right also, then they start having more chances of PJK, and then everything that comes with that. And the problem with this one is, you guys starting your practices very soon, and some of them you guys just few years on it. If you start collecting these patients, it's not only hard for you having all these people complaining all the time, but the problem is at the end, they end up next door with the other guys having the big deformity surgery when you don't have it. And if this one happened 2-3 times, trust me, your reputation is really bad. And I've been in a couple of cities in my life practicing, and you start recognizing who are the offenders, and people know, because the outcomes are done good, then you start having issues, So then the other thing is, and again, it's not a question that when the plumb line goes anterior, all the quality outcomes measurements go all over the roof, you know. And again, you know, it's multiple papers. You see a little bit of the reference in here, but the best ones are the, you know, Justin Smith, Chris Shafi paper. They show very good at doing. And then obviously the group of Glassman and all the ISCG guys, we definitely found, even doing MIS or open, if you don't really restore the lumbar lordosis, then it's a lot of symptomatology. And this is actually a very interesting number, you know. If you don't able to check all the spine, your lumbar lordosis doesn't match with the pelvic incidence, it's a 10 times more incidence to have adjacent level on this group of patients. So this is a big deal, you know. So you know, it's not like I mean, we don't understand 100% proximal junction failure, but we know 100% if you feud these people flat, they're gonna come with adjacent segment failure. And the problem is everything starts with the first fusion of the second level, you know. It's not like that. So what you don't want is to have that. And this is why, you know, look at the spine, which is very interesting. When you look at the lumbar spine, watch this, between 4.5 and 5.1, you have 2/3 of the lordosis. Take a look, for example, how critical is 5.1. 32 degrees is in average, the angulation of a normal spine of 5.1. So if you put like that, it's like crazy, you know? So just imagine you're doing on this patient, for example, a 5.1 TLIF, just put a little cage with very little lordosis in here. And you don't do any facetectomies, nothing. Let's say that you do a mini open TLIF. I mean, you're gonna lose a lot of lordosis, then this level will shut down, and then someone is gonna come and do a lateral or whatever. They don't provide enough lordosis, then you're ready with the monster. Then the rest is T10 to iliac screws, you name it, all the morbidity that comes, you know, with the big procedure cases. Not to mention if you end up doing a PSO or something else, you know. So that's why it's so important. 4.5 and 5.1, we need to be super efficient, you know, because this, you don't provide the lordosis at 4.5 and 5.1, then you create the monster, you know. So then the other thing is, I wanted to know how many of you guys actually, or your attendings, do routinely 3-foot standing x-rays on the patients, even patients with a spondy. It's something that you do it a lot, or just like, oh, it's a spondy, just, we don't need, this is not a deformity, just do the case and she will do fine. So how many of you guys do actually scoliosis films in patients with no scoliosis, like with just degen cases?
We're routinely ordering EOS film, so
that's even better. You're very fancy, you know, as you see here in this picture. I mean, you have EOS, that's amazing, you know. Yeah. But not everybody has access to EOS, you know. But at least I would say 3-foot standing is a big deal, especially, for example, in the spondys, because usually a spondys comes with a high pelvic incidence. We need to make sure that we're not really getting short, you know. And that's very important, you know. The other thing is, I would say there is many sagittal and spinopelvic parameters, but I would say, to me, the most important ones are pelvic incidence, lumbar lordosis, pelvic tilt, and then obviously the, you know, the plumb line, yeah? So as long as you know how to measure that parameters, you'll be good. The other thing is this one, which is very interesting. The TPA is becoming a hot topic lately, you know, because you can match the pelvic incidence to the age of the patient, which helps a lot. But the message is, don't forget also, you cannot get too crazy, because sometimes then everybody becomes crazy, and every time you have a patient with a little mismatch, like a single level spondy, they end up doing like an ACR or a you know, PSO or something like that. You know, you have to understand that also you have to use common sense. You have a 70, 80-year-old patient. You don't want to provide lordosis like a 50-year-old patient, yeah? So that's very dependable also on the age, you know, and that's something that you have to keep on that. So this is just a little bit to remember you basic concepts on the spinopelvic parameter. Don't forget the pelvic incidence is a fixed parameter, as you see here. No matter how you move your pelvis, anteroverted or retroverted, and you throw the patient on the air, the pelvic incidence is a fixed parameter. You know, there is a range that usually I would say 40, less than 40 is a low pelvic incidence, more than 60 is high pelvic incidence. So say 40 to 65 is kind of you behave. And which is interesting is that there is no variation of the pelvic incidence as you age, you know. And what you want, the best patients are patients like this one, you know, when the pelvic incidence actually is low. So the more flat we see the S1 end plate, actually the lower is the pelvic incidence, actually the less lordosis you need to give to the patient. So it's actually a easy case. So and then you see here, for example, this is on the left, this is a patient with a high pelvic incidence. Take a look how much lordosis you need to match this angulation of the pelvis, you know, to be able to have good sagittal balance. But if you're looking here on patients with low pelvic incidence, well, this patient needs very little lordosis to keep it together. So in other words, is ideally when you have patients with low pelvic incidence, no matter what you do to them, they're gonna do great, you know. That's why every time I have a patient in the clinic that comes with a big pelvic incidence, I always like, this is not gonna be good, you know, because you have to keep up trying to give the amount of lordosis to put this patient together, you know. So it's very important that you always have to have that one into control, you know. The next one that is very important is the pelvic tilt, yeah. The pelvic tilt is very interesting because it's a compensatory mechanism, but unfortunately, not everybody has the ability to compensate with the retroversion of the pelvis, you know? So you see here, when you have a really good way to retrovert your pelvis, you know, so you move your pelvis back, then you're able to actually compensate for the loss of lordosis. But if you don't have a good compensatory mechanism like in here, and you keep your pelvis in anteroversion, take a look what happened. The plumb line goes anterior, and then you have a lot of symptomatology. So this is why it's so important that you need to know how much of pelvic tilt the patient that you're going to do surgery is having, you know? Because also, for example, if you have a patient like this one, with a big pelvic tilt, you think the patient is compensated because he has a good plumb line. But the problem is this patient, if you, for example, don't give it a little bit of lordosis, you're gonna put this patient in a huge risk that is gonna end up anteriorly if you lose a little bit of lordosis, because he's using absolutely every compensatory mechanism to that. So just to remember is the patient with high pelvic incidence, I always make this joke, you know, it's like, remember J-Lo, big pelvic incidence, Mike Jagger, low pelvic incidence, you know, flat back, nothing there, you know, so don't forget that. That one, if you remember that one, you always remember who has pelvic incidence high, who doesn't have it, okay? So then how you calculate it, so I don't want to get into details, but and don't forget, it's very important to have them, all of them in mind, and thanks God that we have all these softwares nowadays that do it for you, yeah? So then, but then the question is, you go and practice in a small community hospital, you fighting with your CEO, he doesn't wanna pay for a scoliosis machine. Finally, you can have it, but they don't know how to stitch it. You cannot even see anything. It's like a mess. So the good thing is that as long as you have a X-rays that you can see good S1 lateral mass, you can see the heads of the femur, and L1, actually you can measure the pelvic incidence, you can measure the pelvic tilt, and you can measure the lumbar lordosis. So you actually have everything. As you see here, you know, you have the software nice on that. You can measure everything that you actually need. So you have an X-ray that give you these parameters. Actually, you can have an idea what's happening with that spine. But then you have to be careful. I'm gonna show you later on. If you're not careful, you also can get burned if you don't have a good idea what's happening on the thoracic spine. That's why it's so important. If you don't have a 3 full standing films, you need to look at that patient walking. Because if you see that even in here, the numbers, let's say, for example, this patient, the numbers, all of them are within the box, but the patient is leaning forward, you need to make sure that nothing is happening up there, you know, and that patient may need a scoliosis film. So you have to use also common sense in that when you don't have that. So at the end, as I always try to show this, is the patients comes on 3 different groups, I would say. The green patient, this is the most common patient that we have, you know, unless you're doing a dedicated deformity practice. But if you're having a regular degen, traumas, deformity here and there, most of your patients are gonna be what we call the green group, which all the numbers are within the box, or patients on the yellow group that can be a complicated patients because these are the patients that are using every compensatory mechanism and you have to provide some lordosis. And then finally, you know, you have the patient that everybody knows that are going to your clinic because it's the guy that is totally crooked, you know, sideways, that everybody knows that is having a huge deformity, which is, you know, that need a big surgery and that's it. The problem is the yellow group, to me. It's always been the patient that have been having problems. That woman that you saw there at the beginning, there was a patient that it was just right there, able to compensate her posture, but she was losing already a lot of lordosis. And then if you don't provide a procedure that gives lordosis, then you have the complication, you know? So then the question is, how do you produce lordosis? You know, what surgery, what procedure do you have to do that? So obviously we have a big armamentarium of procedures. So I'm gonna ask you, each of you guys, and you tell me which is your champion procedure that you think you use most of the time and give you good lordosis. What about, start with whom? Maybe what is the order in here? Let me see. You guys start talking and tell me.
I can start. Yeah, I think we certainly do a lot of ALIFs at 5'1", and then
that's awesome.
And then a lot of laterals or anti-psoas from up there. We do not do a lot of PSOs and kind of the more invasive correction procedures. Not a whole lot of T-lifts for sagittal alignment.
Yeah, and it's very interesting because, I mean, you ask me, obviously, you know what I like. You know, I love ALIFs, I love laterals. But what's interesting is that if you ask Lenky, he will say, I'm doing less and less PSOs every year, you know. And why? Because the morbidity that comes with PSOs, you know. So what about you other guys? What are you guys doing?
We're doing a very combo of things. I mean, we lift for lower down, a lot of laterals if we need to, with ACR if you need it.
Oh, that's awesome.
Some T-lifts, depending on if you need to rely on interbody fusion higher up, but usually lower down A-lifts, as many as you can get. And then if you can't, then do a lateral or a T-lift.
Yeah.
We actually rely on positioning. We make sure we maximize the lordosis just with positioning. We have a bendable table. Oftentimes we don't need to use any sort of interbody device. We just use positioning and posterior column osteotomies, and that typically gets us what we need, but otherwise we'll do A-lifts or T-lifts as needed.
That's awesome.
Yeah, I would say, you know, echoing what others have mentioned, ALIF, then XLIF, and then TLIF in terms of trying to get power for our lordosis. And then in the back, you know, we still do PSOs here, but more commonly Smith Peets just to lower morbidity and blood loss and things like that. Obviously positioning is important, but that kind of sums it up for us.
Who's the one doing PSOs there? Themi?
Yeah,
I heard that
he does everything.
Laterals and MIS lately.
Yes, he is for sure, and I think also a big thing that is kind of come into consciousness is how to be most efficient. So, you know, single position, not prone, but single position lateral, doing A-lifts, and then doing what you need to do in the back.
So who's next there?
Yeah, hi. Sorry,
we get a lot of.
I didn't.
Go ahead.
Sorry, I didn't introduce earlier. I'm Zach. I'm also at the Harvard program with Jeff Kanaka. I think for us, we really try to get ALIFs certainly at 5'1", and also at 4'5", and then rely pretty heavily on positioning. soft tissue releases, posterior column osteotomies to get lordosis. And then, obviously for fixed deformities, when we can't, do anything else, we do a PSO.
Yeah. Mm-hmm.
That's what we do. In my training, we did almost all posterior column osteotomies, very few interbody fusions.
Yeah.
And then fellowship, it's almost exact opposite. So a lot more interbody fusions and then a couple PSOs sprinkled in.
Wow. That's awesome. Yeah, it's amazing. It's a huge, as you see, any one of you guys mentioned TLIF, which is awesome, because, when I was trained, TLIF, still, I think, no, Peter, Marzano, are you there, or Mike?
Yep. It's,
what percentage
globally, TLIF is still 70% of interbody fusion.
Watch that, guys, huh? It's crazy because you guys are young and you belong to a new generation. I would say the way that we see it, ALIFs are taking over on 5-1, almost 100%. Yeah, but I can tell, the trend is more ALIFs, more lateral, less TLIFs, less posterolaterals, which is, I think it's great because for the lordosis is amazing, Nothing better than an ALIF on 5-1, no matter how you do it, lateral, supine, it's an amazing procedure, okay? So then the question is how you achieve lumbar lordosis. So you guys nail basically everything that I want to show in here. So one is positioning, this is very important. That's why, for example, I'm getting so much right now interested on prone laterals. It's because I've taken not only this procedure itself, but also the positioning. We know that when you put the patient prone in a Jackson table, and if you listen to Lenke and Shaffrey, and there is a couple of good papers. This one from Jonathan Sembrano from Minnesota, the guy who worked with Polly, showing that, the difference between lateral and prone, for example, or supine and prone is a big deal. You get 5-10 degrees of lordosis just by putting the patient on prone. So position is very important, You have to be aware that when you have a lateral, you have to do something, to compensate for that. And then obviously the procedures, as we know, ALIF, lateral, TLIF, you name it. But then you have the real lordotic procedure, which are the osteotomies or the ACR, but you know that we cannot do, posterior common osteotomies on ACRs on every patient because the more we do, the more risk we take. So, I love ACRs, but I'm trying to do only when I have to, because I know that if I go anterior and I hit one of the vessels, complication is horrible, yeah? Same thing with PSOs, PSOs are, morbid conditions. So sometimes it's better, for example, do a bilateral facetectomy and just an XLIF without the ACR, and then you get good lordosis, or just an ALIF itself that by straightforward give you a good lordosis, yeah? So I'm gonna show you a little bit what give you each osteotomy, because I think this one, I get this question, actually I present this slide a lot when we're trying to prepare on the neurosurgery boards courses. We show this one a lot because when you get into the board, they like to ask a lot. When the guy that is presenting the boards comes very cocky, oh, I will do a posterior column osteotomy, this and that. They start like, oh, okay, let's talk about that, So we need to make sure that you guys exactly dominate which one does and what is for and what is good for that. Because the last thing that you want is to kill a quail with a bazooka, yeah? So, and this you have to be very careful. So let's see all of them. PSO is the, posterior column osteotomy. I will say is the best way to name the manipulation of the posterior elements. They have like a million acronyms, and this one is when you call the Smith-Pitt osteotomy, yeah? And also they have the chevron osteotomies, the Ponti osteotomies are also in this category. There is a little bit of semantics different that we're gonna talk to that, but if you say that like a Schwab 1 or 2 is the same that a Ponti osteotomy, and Ponti listen to you on that, he will yell at you. He will find you someone in the world and yell at you, because Ponti, for example, decided his osteotomy is only for Sherman kyphosis and it's very clear, while, the regular Smith-Pitt osteotomies is a little more extensive than the Ponti, and then the Schwab, he just grabbed them and put numbers on it, So it's semantic that we don't want to go, but which is interesting is a facetectomy with a laminectomy in general give you 10 degrees a little bit on the general side, but usually 5 degrees if you do it by your own. Let's say, for example, you do multiple, let's say you have a Lenke style. So you have a patient that needs 20 degrees of lordosis. So what they do is they put it on the Jackson table, they do facetectomies of posterior column osteotomies, Schwab 1 or 2s, that is also a name, at 2 or 3 levels, and they give 3 to 5 lordosis per level. This thing changed a little bit if you go and you put a cage of, let's say, a TLIF cage way anterior, and you compress, you can give a little more, that's when you can give 10 degrees of lordosis. But if you just do a facetectomy by your own and you do a posterolateral fusion, it will give you 3 to 5 degrees, okay? The next one is the PSO. Obviously, the PSO is a very aggressive, as you know. You have to take all the posterior elements out, then you get into the vertebra and you do a V-shaped osteotomy, and then you close it. You know, very powerful, amazing the amount of lordosis that you do. And as you know, the PSO usually give you 20 to 30 degrees per level. But what is the problem? It comes with a lot of comorbidities, you know. PSO in the best hands, 800 cc's of blood loss, you know. And the complications, 40%, you know. That's why we do ACRs, you know, because ACRs, when you cut the ligament going from the lateral, I mean, the complication can be brutal. But the problem is the ACR can give you a lordosis or a PSO. That's why we say, well, listen, we do ACRs because the other side that is PSO is not like a little Mickey Mouse surgery, correct? And then the last one, the maximum expression of the osteotomy is obviously the corpectomy, yeah? So you take the whole vertebra out, and then you move the spine back, and that one you can have as much as you want. You know, the thing is, most of the corpectomies, you start with a kyphotic level. So that's why you give 40, 50, 60 degrees of lordosis on all of them. So these are the 3 principal procedures for that. You know, obviously the ACR fits on the PSO kind of amount of lordosis that you give, you know. Then you're looking here, how much procedure will give me any lordosis. In general, when you do a posterolateral fusion without nothing else, you just go back and you just put bone between one transverse process to the other one. I mean, you cannot have maybe 1, 2 degrees of lordosis, you know, it's very bad. Then if you do a TLIF or PLIF, you can have, you know, 5, 10 degrees. And then if you do a TLIF plus, that is a Chris Shaffrey procedure, where you do a TLIF and you take the facets and compress, then you have that lordosis, you know. And then obviously the ALIF is amazing, yeah? Take a look at the ALIF. You just go and put a cage that is not really hyperlordotic, you know, you put a, and then, you know, using here, if you do an ALIF and a facetectomy, then we're talking about huge lordosis. And then obviously when you start doing ACRs, it's similar to the ALIFs, but, you know, with a different way to get in there with a good results, you know.
Quick question for you, Dr. Uribe. So you make many of these decisions preoperatively. Do you do anything intra-op to determine if you need to combine a PSO with your ALIF or anything like that? How do you understand it as you're going?
Yeah, that's a really good question. Usually, you know, you come to the OR with a plan, you know, and usually the way that I function is, if I need more than 20 degrees to compensate, I know that I have to do something more than just go and play cages. So I have to do an ACR or an ALIF with a hyperlordotic cage. And then what happens is usually you start down, you know, building your case. You do the 5-1 first and you put a hyperlordotic cage. If the 5-1 responds good and you think that you're getting significant lordosis, you start dialing down 4-5, 3-4. But if you do 5-1 and you don't really see too much change, then I know that I have to start doing facetectomies or something else, you know. Sometimes, you know, because I like to do it MIS, so I do it in stages, you know. They say first day time I do, you know, the laterals, and then after that I can do a facetectomy, so far or not. But yeah, you have to be prepared to change. You know, we have some ways to measure in the OR how we're doing. It's not as precise as standing the patient next day, but that's the way that I function. So So that one, you know, just to go over the cases that you guys have is always remember your alignment objectives, you know, you have to keep all these parameters, you know, everything you do within the box, you know, the lumbar lordosis has to be proportional to the pelvic incidence, you know, plus or minus 10, you know, make sure that the pelvic tilt, you reset the pelvis, you know, you don't want to leave the pelvis, you know, retroverted. And then the other thing is I want you to look in here on this case. So watch this, for example, this is two patients with x-rays L1 to the pelvis, as you see here. You measure the lordosis, 43 degrees, 43 degrees. But then watch, this is very interesting. So you measure the pelvic incidence, patient on the left, 35, patient on the right, 76. So take a look what happened. So you look at this case, actually, if you don't give something special on this patient, or in this case, for example, if you don't have a good 3-foot standing, take a look at the difference, you know? So these are day and night. So how come two patients with the same lordosis, the one on the right is totally out of balance, and the one on the left is actually compensated like crazy? So this patient on the right, you need to know what's going on in here. You know, something is really happening in here, yeah? So he has 76 pelvic incidence, only 43 lordosis. This patient is losing lordosis on the lumbar spine. You know, obviously the thoracic looks a little bit weird, but this patient is actually pretty much full compensated. So that's why it's so important that you need to have an idea what's happening in each patient so you don't get short, you know? So I'm gonna show you, for example, another good example. This is actually the other way. This is a patient of mine, grade 1 spondy, as you see here, is moving on flexion extension at 4.5. And then this is the MRI that basically reduces 100%. And then this patient, which is interesting, is when we got the 3-foot standings, take a look how crazy is the numbers on this patient. So this patient has a grade 1 spondy at 4.5. Everything else was normal. The MRI looks amazing, by the way. And then out of balance, if you look in here, lumbar lordosis 23, pelvic incidence 45, you know, so he's losing at least 15 degrees of lordosis, 10, 15 degrees of lordosis to be on the conservative side. The question is one of you guys help me? How you handle this patient? What will you do with a patient like this? Anybody there of you guys?
Because ask if their knees are bent. We know, you know, that's one. We don't have a big standing.
That's a great pick.
Yeah. So we make our X-ray technicians verify and put that on the X-ray that we at least knows that their knees are locked.
Exactly. Yeah. So one of the problems with this patient is technically it's not a good picture, you know, and this guy probably was in pain. He didn't really make a good job of standing. The problem is you're not gonna believe this patient actually. When I was in Florida, I was one of my partners, and junior partner, you know, he was very excited with this, you know, spinopelvic parameters and everything. He was telling me, Juan, what do you think about doing an ACR at 4.5 on this patient? And include 5.1 and doing an ALIF, and then doing something on 4.5 because this patient needs lordosis. And I was like, my God, you know, this is the problem when you push too much in something and then you end up crazy. So watch, this guy he was planning on sacrificing that perfect normal level just to be able to give lordosis that probably if you control the position of this patient and take another picture, it will not be as bad as you think, yeah? And then what I would say in this patient, what you need to do is you need to make sure that you don't do a surgery that you don't lose lordosis. You have to provide a little bit lordosis, but I will not recommend you to do like an osteotomy or crazy things, you know. In this patient, for example, the best way to do it probably was, if you're looking here, you know, is you see 4.5 is losing a lot of lordosis in here, but since it was such an unstable segment, I'm sure that if you put a 15 degrees, like a lateral cage, you can give, you know, 3, 4, 5 degrees of lordosis, and that probably could be enough for this patient. And you don't want to go and start doing osteotomies and crazy things on that, you know.
Hey, Dr. Uribe, I have a question for
Yeah.
you. So what about those kind of neurogenic patients where they're kind of pitching forward more to relieve some of the pressure rather than, so it's not necessarily a compensation mechanism, but more so just they're kind of trying to bring in some kyphosis in the lumbar spine to decompress the canal itself. Do you have any kind of tips or tricks that you're doing? Just like, you know, you're looking at them on the films. Is there anything that you're specifically looking at, or is things that are going on in your mind?
Yeah, and it's very interesting. You know, there is a very interesting SRS paper on that, you know, especially on patients with neurogenic claudication on lumbar stenosis. You know, that patients, you take like a 3-foot standing films that we have in here. And if you just go and do a laminectomy on those guys, suddenly the lordosis comes back. It's because the initial mechanism to compensate for the stenosis, as you mentioned, Michael, is to bending forward, you know, trying to open things a little bit. So you also, so all these things you have to take into account, you know, if he has too much stenosis, why this patient is like that, is the patient on pain? Also, what, as you guys picked it up, is he bending the knees? You know, what is the reason? That's ideally you should have an EOS on everybody, you know, but obviously, you know, it's a $1 million toy that is still on development, you know. So I don't know, you've seen on the EOS, if I take an EOS and I want to magnify, for example, the lumbar spine or the cervical spine, I can see nothing. It goes pixelated, you know. That's why, you know, if you give me that machine and I can, you know, magnify, and it's like I took a cervical, thoracic, and lumbar and extremities, I will, you know, probably everybody will have it. I'm begging, I mean, I'm crossing my finger that GE and the big, you know, Siemens, these big companies comes with a more affordable software that you can include it on regular machines and people can have these images, you know. But you see here, the point is that you have to be careful not to fall on this group, yeah, but also not be too crazy and be overreacting when you see these images, yeah? So you need to be on the bus. So the takeaway images is, message is, I mean, global alignment to me is critical. You know, if you're a modern spine surgeon and you bring in a patient to the OR and you have no idea what is the relation of the pelvis with the lumbar and the thoracic spine, I mean, you lost all your time on training because you're gonna create a group of monsters and we cannot keep, you know, for example, my practice is all about fixing flat backs, fuses 5-10 years ago by people in the community. You know, we don't want to keep doing that, yeah? And then, which is very interesting is, it's very easy to provide the first surgery, provide the good lordosis that the patient needs, than later on go and put the patients to a monster surgery. Remember that my first case that I showed you there. And then obviously is every time you fuse someone, take time and find out if I'm doing this level, I'm really keeping up with the lordosis that this patient should have, you know, because this is a fine line. And don't forget, 2/3 of the lordosis is 4-5 and 5-1. You keep that one in your mind, you're gonna be great, you know?
I want to ask you a question, Dr. Uribe. One of the things that I think is important that you bring up is maybe intraoperative assessment. And so outside of kind of eyeballing things, we utilize a lot of SurgiMap more for our deformity cases. But are you routinely using any specific program for normal degen cases or even for deformity cases?
Intraop, yeah, intraop, you know, I'm blessed because I have a good relation with the Nuasive guys and we have full S-ray, you know, and all the application from that. And we have a way to measure a lot of things real time. But I can tell that, you know, there is a couple of software that you can still use intraop to help you out. But don't forget, the best thing is what I do when doing cases is, as I do levels, I explain Mike, I touch base right away how much lordosis I provide on that level. The problem is don't forget, if you put a 30-degree cages, doesn't mean that you're gonna go 30 degrees of lordosis, you know? And this is something that sometimes people think on that, you know? So you need to make sure that you actually getting, you know, for example, 5-1 to me is the big deal. When I need lordosis, I always start with 5-1, trying to put the more hyperlordotic case that I can use. But also you have to be aware because the level sometimes don't give you what you need. And then you create this pocket of air, like a triangle pocket of air on the back of the vertebra that is actually not the real lordosis, you know? So you want to make the way that they sit together and they sit on the end place right. So some people fits better 20 degrees, 30 degrees. When I need a lot of lordosis, what I do is I start doing the facetectomies on 5-1, then I do the ALIF, that thing open up amazing, you know? That's something that I do when I need more than 15, 20, 30 degrees. I start with that, you know? So, but definitely I use less rate a lot to help me to have an idea where I am compared to pre-op.
Dr. Uribe, I'd just like to hear, you know, your main
Technical tips to maximizing lordosis with the lateral. I mean, short of an ACR, you know, obviously putting the cage up front, you know, fascectomies, what else can you do?
Okay, so yeah, I'm gonna tell you what are the tricks, okay? So the most important thing is before the surgery, you have to learn to identify what are the predictive factors, not only to give indirect decompression, but also to give you some lordosis, you know? And I'm gonna tell you a little bit of points, and it's actually, this paper we just submitted now is like a two parts paper. It's called Predictors of Indirect Decompression and Lordosis, but I can tell you what we found, okay? If you start with a level, that's why it's so important to have a CT pre-op. If you have with a level, especially for a lateral surgeon, when you start with a level that has vacuum phenomenon, that thing gives you a lot of lordosis. You know, I always say the best friend of the lateral surgeon is the vacuum phenomenon. You know, when you see vacuum phenomenon, I mean, even without doing interbody, you get a lot of lordosis, you know? So vacuum phenomenon is amazing. So every time I see vacuum phenomenon, it has to be 15-degree cage or more, you know, and you don't really need to do ACRs, you know, you need a lot of lordosis. Okay, the next good factor.
You're saying 15 degrees just from putting a lateral up front
and compressing in the back?
No, just the cage itself, you know, you put a 15-degree cage, you know, obviously it doesn't give you the 15 degrees, but that level with vacuum phenomenon, they can take 15 degrees cage very good, you know, because the problem is the level is not made to give you 15 degrees. What you do is you force a cage and then you leave a lot of the cage not even touching the end place. So you're actually not giving the lordosis that you think. It's like on your mind you think, but it's not giving anything. So the next step is, obviously you need to see how the facets are pre-op. Again, the CT is a big deal. You know, make sure that the facets are not fused, or on the MRI you have hyperintensity on the facets. That level is going to work with you. So that levels also you can try to give lordosis without the need of the ACR or without the need of facetectomies. And then the next level up is, if you are good with lateral, then you come with the ACR. The ACR is amazing. You know, I mean, once you cut the anterior longitudinal ligament, you put a 20 or 30 degree cages, these things is like, I mean, this change that. The problem is that ACRs, if you don't do it right, you're going to kill the patient, yeah? If you go into the vessels, that's, you know, and also you have to be already in a good level, you know, in a good level of expertise to handle these cages, because these cages, once you cut the anterior longitudinal ligament, they like to go anterior, you know. You put it and then the cage start looking anterior, you know. So actually right now, Mike, when this cage is gonna get on the market, the new expandable?
Going into alphas early next year.
Okay, so these cages are gonna be amazing, because what we can do is you cut the ALL, you put the cage, you fix it to the vertebra, and then you start opening, and it open up to 30 degrees if you want. You know, that one is gonna make, I would say, ACR a little more easier. The other option is, if you're not, you're afraid with the ACRs, is you put your 15-degree cage on the front, you didn't get the lordosis that you want, but then you go back, you do facetectomies, and then you compress. That way you close the air pocket, and then you give lordosis, you know. But in general, that's the way that I function. But what I use a lot is, how much lordosis do I need to get what I want? And my magic number is 20 degrees, you know. So if it's a single level and I give 20 degrees, I mean, usually you don't have that patient. That's a very awkward patient. Usually you do in multi-level cases. So I always start with the ALIF on 5-1. I use a hyperlordotic cage. Usually give me 5, 7, 8 degrees of lordosis, even putting a 20 degree. And then you go building the next level depending on what you have, you know. And then if I need more, way more, you know, like a 25, 30 degrees, I start with facetectomies first on the back, and then I do the anterior column, you know, reconstruction. And then—
Are you doing the ALIF in the lateral position as well?
Depending, yeah, depending also. If it's a patient that doesn't need too much lordosis and is straightforward, you know, one level, I give it a shot on lateral. But if I'm going multi-levels and I need a lot of lordosis, I still do better with the supine patient on supine, you know, because I can go side to side from, you know, from the one L5 nerve root to the other one, and then cut the entire ligament, crack it, you know, open it up, and then I can put the big hyperlordotic cage, which I haven't been very successful doing with the patient on lateral, you know. So each case to me has its own, each patient has its own advantages, you know. But I would say the other option, and the other one is obviously start with the facetectomy on the back. If you start with the facetectomy on the back, you can go on the lateral position and put the hyperlordotic cage, but then, you know, it becomes a big surgery and you want to flow, you know. So, but that's basically the way that I function with the ALIFs, you know. But I can tell 5-1s, 99% of my cases are ALIFs, you know. I play between lateral and supine, depending how it is. Also, to me, the lateral, the success of lateral 5-1 is, I would say, it's 100% dependable on your access surgeon. You know, everybody can put a cage from lateral. I mean, the surgeon doesn't need to do anything besides put the cage and 2 screws and walk away. The lateral 5-1 is 100% dependable on your access surgeon. So you have a really good access surgeon, you do it all the time lateral. But you have a guy like what I notice in our institution, you know, we have a lot of spine surgeons in here and a couple of access surgeons. The old access surgeons, which are very good doing supine, they're very reluctant to start doing the laterals. I live from laterals. The young guys, they really adopted fast, and at some point they like more to do the approach in lateral than supine, you know. So it's at the end is what access surgeon you guys have and pick, you know. Nuesive is doing very good because they're having this good training group of access surgeons that actually they're becoming like a more standardized how to do the access on laterals. So how many of you guys are doing the ALIF on lateral position?
We do a fair amount at MIU, ALIF and lateral.
Yeah. So you guys have a really good access surgeon for that, correct?
Yeah, yeah. We have 2 access surgeons who do either supine or lateral, but they're comfortable with the lateral as well.
Any other question, guys, or something you want?
Dr. Uribe, when you are thinking about ACRs versus a standard XLIF with a posterior column osteotomy, what % of the time are you doing the ACR versus doing the standard XLIF with the PCO?
If you don't take me wrong, because I'm biased, you know, and I'm like ACR, I do 80% is ACRs, you know. To me, PSO, so posterior osteotomies, is only when I have to give lordosis through a few segments, you know, when you don't have a disc space to work, then you do PSOs, you know. Or when I need to do more lordosis that the ACR will give me, I do facetectomy, so I do a big ACR, you know. But don't forget, I'm a little bit on the deception side because you know, I like ACRs a lot, but I can tell friends that are very good at XLIF, like a Tony Juan, people that they don't feel comfortable doing the ACR. What they do is they do facetectomies and they put the XLIF cage until and they compress, and you can have a really good lordosis as well, you know. The thing is that I like the ACR because I just go in one shot, I get out of there. Because, you know, the facetectomy is, even if they're easy, it will take me 30 minutes, 35 minutes, whatever, do it, you know, through the tube or whatever it is, you know. And the patients go home faster if I just put the pedicle screws percutaneous and walk away, you know.
So for the ACR, tips and tricks for doing it safely to avoid that disaster where you hit the vessels.
I'm gonna tell you the best trick. Okay, the best trick is, you know, the MRI pre-op and the CT, looking at the vessels, that helps. But I will use it just in case that the patient has an aneurysm, he has a very awkward thing, you know. But in general, this is the way that it works because, you know, don't take me wrong, it's very stressful when you do an ACR, you know, because the complication can be really bad. So the way that I handle it, because you know how it is, we as a surgeon, when we have a big surgery next day, you wake up 2 or 3 times in the middle of the night, yeah? You're like, oh my God, tomorrow, you know, and you imagine the worst, yeah? So what I do is this. Usually when the residents on the scrub tech, whatever, they ask me, hey, are we gonna do an ACR? I usually tell them, I'm not sure. We're gonna see what happens. And the way that I do it is, I start doing the XLIF, I find the anterior longitudinal ligament, and then if I see that the plane develop easy, that's an ACR. But if I start struggling, I don't force it because usually the plane is there and you can dissect it very easily. You know, Nuasive has these nice dissectors, you know, and once you get easier, to me it's an ACR. But if I start struggling at the beginning, I just walk away, you know. I can tell 90% of the times I don't have any problems. I've been lucky, I never have a vascular injury, but it can be next week, who knows, you know, but I will say the way that I do it is I use a lot of common sense. If it dissected easy, it's an ACR. The other thing is also when the time comes to cut the ligament, you know, you already dissected, you're in front of the, you know, you have the ligament in front of you, you start cutting it, but then when you start opening the ACR, you have to do it very slow, you know, because if you do it too fast, you know, you can, you know, this patient had osteophytes, you can, you know, avulse one of the segmentaries, you can bruise things, you know. It's a very slow, you keep opening, and then it's very interesting because at some point you lose resistance, you know, and then you do it. Another way that I do it also, which is very efficient for me, is patients that have a big osteophytes, they're kyphotic, the level looks a lot of degeneration, you know, almost bone in bone. That patient actually, you start doing the XLIF, and what I do is I start with an 8 trial, 10, 12, and suddenly this thing opened by its own. So I not even need to go and dissect the ALL. The ALL pops out by itself because it's an old bad ligament. You know, a ligament is not moving anymore, you know. So what you do is you put some stress and suddenly pops out, you know. So that's probably the safest way to do. And a lot of time you're lucky, and that levels is very interesting because you start with some kyphosis, so they give you a lot of lordosis, you know. Anything else?
Dr. Uribe, what are your thoughts on ACR at higher lumbar levels? Are we putting the apex too high with that?
Yeah, so I only do it when I have a kyphotic level, you know, so let me see if I can, I don't have control. Peter, can you go to the first case, the one that showed the CT? So you see that one was a high ACR. You look on that case, on the very first case, there is a CT that show like a, see that CT, yeah. The one on the top, the slide on the top right there. The other one, the one before. Okay, just click forward. So see how it was? You see that 5, 4, 3, 2, 1, 2 is an ACR there. But if you look, go one click back, Pete, take a look how was 1, 2 right there. Kyphotic, bone in bone, you know, that's like an ideal case. So you see here, the lordosis at that segment is probably negative. It can be like, you know, -2, 3. And then if you move forward to the next one click, Pete, watch this. It gives not too much, as you see, but the problem is we started kyphotic. So this is, for example, a good example when high PSO works, you know, because you're not really, and it looks very physiological. And then also take a look how powerful was 5-1 on this patient. Go one click back again. Take a look how was 5-1. Sometimes people think that when you have these calcified anterior osteophytes, you can, the ALIF is gonna be very hard. Actually, you have that, tackle it because they work well. And this patient, what was great is this patient has a laminectomy long time ago at 5-1. So take a look at how it changed 5-1. One click forward. Take a look at this. The big lordosis on this patient was actually a 5-1. What's this? This is a 30-degree lordotic. So what I did is, you see only one screw on S1. That way I still have the option when I was putting the patient prone to give more lordosis, you know? And then you see 5, even in 4-5, also, believe it or not, I also did an ACR because I was desperate to give lordosis and not to give that. Every time you see a screw in here, you see that? It means the screw on the vertebra means that it's an ACR on there. But see, this one is only a 20-degree cage. And if you look, there is a little bit of vacuum on the top that actually didn't take the whole lordosis. But if you go back again, one click, take a look, also 4-5 gave me a lot of lordosis. You see, 4-5 was a vacuum phenomenon, almost no lordotic, and then go there on the next one. You see how much. So in this case was amazing because each level that I did gave me a lot of lordosis, you know. If you give this case to Lenky or those guys, probably they will be doing on a PSO somewhere on 4-5, you know, somewhere at 3-4, and then they will do a bunch of PCOs on everywhere, yeah? So, but you see that's when a PSO works on the higher levels. If you have a good lordosis on the higher levels, actually the ACR don't give you nothing, you know, because the levels on the top, they're made not to be hyperlordotic. So if you really want to give lordosis in one of these levels, you have to do a PSO, which also the open deformity guys hate it because, as you mentioned, the physiologic lordosis is usually a 4-5 and 5-1, not at the higher levels. Yeah.
Yeah. So, you know, Dr. Uribe, you know, obviously an extensive experience with lateral surgery. How do you prepare yourself, you know, to deal with a vascular complication, or what steps can you take to, you know, be confident that you'll be able to effectively, you know, manage a vascular complication? Because I think, you know, all of us have put in an XLIF and felt good about ourselves, but, you know, what about the worst case scenario? Like, I'm just wondering for myself what I can do to, you know, be completely prepared to, you know, deal with that complication in an appropriate fashion.
So that's a great question, Zach, and I'm gonna tell you something. The first thing that comes to my mind, I compare XLIF to flying an airplane, you know? How much you tolerate an airplane falling, you know, crashing? It's almost zero, you know? Why? Because, you know, when you fly in an airplane, it's too many little pieces, but always is so much standardized that the complications, you know, the accidents happens very rarely. So I can tell you is, I done around 1,600 XLIF in my experience, and for some reason, I never have a vascular injury. And I think because it's a combination of a couple of things. One is I'm very stick to the standard surgery as Nuwasi described, you know, Pimenta, Smith, you know, and the company itself, you know. So I always follow the same, you know, the surgery, the XLIF, when I have the fellows and the residents, I usually tell them, this is a very boring procedure because we're gonna do exactly the same steps all the time. And when I see that you can master every step, then you do it by your own. Second is, I never had an XLIF where I was not on the case scrubbing, controlling that. So in other words is, I take every case like my very first case. You know, I never take shortcuts. Like when we do just a laminectomy, you know, so I always be there. Second one is, you develop your own standardization, and if you stay there, it's very hard that you get, you know, like a bad complication, what we call catastrophic complications that are bowel injuries or vascular injuries, you know. I mean, I have subsidence, femoral nerve injury, you name it. You know, I have in almost every complication that exists in the world of laterals, but I never have a vascular bowel because I feared them. Every time you have one of those, you get sued. I mean, you have to be very lucky not to get sued, yeah? But I will say, every time there is a vascular injury, I always say that is two problems happen on the surgery. One is, or you didn't pay attention pre-op and the patient has a variant, one of the vessels was too lateral or something. And the second one that is always happen is the surgeon lose control of the case sometime, you know, because the vessels always leave anterior and the cage always go behind it. So the only way for you to have the vascular injuries, you get out of where you have. So that's why it's so important. The patient has to be perfectly positioning, tape. You always have to work perpendicular. You always has to make sure that it's right there, you know, right there every step, you know. I think that that's the success on these surgeries. And
Well, everybody, Thank you very much for joining us. Really
Thank you, guys.
appreciate it. First and foremost, Dr. Uribe, your time,
guys.
and you're sharing your experience, and certainly all of our participants tonight, including those that created cases. So thanks amongst Yang. Really appreciate it. Be on the lookout for next week's virtual spine conference, speaking about adopting a new technique, an individual's journey with XLIF. That'll be with Ivan Chang out of Stanford. And these videos will be a running series on our YouTube channel as well. So share with your peers, encourage you to check out what's on there, including our case debate series. So other than that, everybody, please be well, stay healthy, and good luck tomorrow when you guys go to the hospital, okay?
Thank you, guys. Thank you.
Have a wonderful night. Bye-bye.
Well, that was amazing. Thank you, guys. I really appreciate it. Have a good night, guys.
Take care, everybody.
Okay. Thank you.
Thanks, Doc.